Sue, you can hear me, right?
Yes, I can.
All right.
You can hear me.
Yes.
Okay.
Good morning, everyone. Thank you again for joining us at University Express Virtual. It's a great addition to our program that we are able to do this in a virtual setting. We also do University Express in person at several of our local senior centers, as well as local Erie County libraries. So you can find a schedule on our website, or if you were to go to a library or a senior center, they would have the schedule as well. So please join us for some upcoming lectures. Now, University Express is a program that would not be possible without our sponsors. And our sponsors are Highmark, Blue Cross, Blue Shield of Western New York, Excelsior Orthopedics, Wegmans, and of course, us, the Erie County Department of Senior Services. And that's where I work. We are located at the Raft Building. And we do also receive a lot of participation from our fellow coworkers here at the county. Senior Services has many offerings. Some people don't realize how many services we offer. And I'm just going to go through a couple of them. So we have our Stay Fit Dining program. This is at 48 senior centers across Erie County. And you can come in for a meal and nutrition counseling. And it's all available for anyone who is 55 or older. You just have to be registered with the senior center. We have Choose Healthy Western New York workshops where you can learn how to better manage the challenges of chronic disease. Now, this could be for you or someone you know. We have the Enrollment Benefit Center. So if you feel that you meet the requirements for benefits such as HEAP, or Medicare, Medicaid, anything that you might need, you can call us and get the information on that. HEAP, SNAP, those types of programs. We also have RSVP. Now, this is kind of an interesting program, but if you're interested in volunteering throughout Erie County, we can help set you up with a local not-for-profit that may be in need of volunteers. And we have a lot of opportunities. So you can find out more about all of these services by calling 858-8526 or going online to eriecountySeniorServices.com or .gov, sorry. And now a little bit about our speaker today. So this is Sue Stoklosa. Sue is a nurse practitioner with 13 years experience in a pulmonary and critical care practice. In this practice, she managed and educated obstructive sleep apnea, or OSA, patients. She recently lectured on OSA at a New York State Nurse Practitioner Conference. She currently teaches the next generation of nurse practitioners at Damon College, which I believe is now Damon University, right, Sue? Yep.
Yes, yes. I need to change that, yeah.
That's right, that's right. She is also a certified basic life support and advanced life support instructor. So we welcome Sue today, and I hope everyone enjoys the presentation. Take it away, Sue.
Thank you, Kitty, for the nice introduction. Good morning, everyone, on this beautiful day, beautiful spring day. If you hear a little buzzing in the background, they're taking some trees down around the house. So that's always something that, when we do virtual things, you can't control for. So today we're going to talk about obstructive sleep apnea. And like Kitty said, managed a lot of patients with obstructive sleep apnea in our practice. So have a few tricks about how to manage it and how to go about diagnosing it. Let's see if we can get to the next page. There we are. So just a few numbers. Obstructive sleep apnea is very common in the United States. And you can see with these numbers, these are from 2014. About 25 million adults are diagnosed with it, mostly between the ages of 30 and 70. The take-home point here is the majority are undiagnosed. That means most people have some element of sleep apnea, but have not been tested or treated as of yet. So a little bit about what happens during sleep when you have obstructive sleep apnea. So it's mostly an issue of the back of the throat, where you have your tongue and then that soft palate, that soft mushy part, you have the hard palate, and then you can feel that area on the top that's soft. And when you sleep, that all relaxes, the muscles relax, the nerves relax, and that area can close up. So you go to sleep, the airway collapses in the back of your throat. No air gets in, breathing stops, sometimes just for a few seconds. We're not talking a long period of time. A message goes up to the brain to say, wake up a little bit and take a deep breath. You take a deep breath, you fall back to sleep, the cycle goes on again and again. And depending on how often this happens, and I'll show you the numbers later, depends on the severity of the sleep apnea. So a few things go on in the body when this happens. So first of all, if you're, let's say, 15, 20 times an hour, this is happening, your body is under a lot of stress. So first of all, you have a lot of then circulating stress hormones that increase your blood sugars, that increase your blood pressure. The other thing, that happens, one of the other things is that it increases the pressure in your chest. If you all hold your breath now for, 10 seconds, you can feel that pressure in your chest. So that affects how the lungs work, and then that back pressures onto the heart. So a lot of times the problems we see with untreated sleep apnea have to do with heart problems because of these pressure problems. It also, depending on the severity, again, if you're stop breathing, your oxygen levels go down multiple times during the night, it's going to affect every organ, your brain, your kidneys, because they all need the oxygen to function. So just a couple things when on kind of the diagnosis and looking at how we risk stratify people for sleep apnea. This one thing I have here is the Ppenworth sleepiness scale, and you may have been asked to do something like this when you have gone to your primary doctor and they ask you to fill out a form like this. And it asks you the chance of dozing on a 1 to 3 scale of these certain things that happen in everyone's life. And then you add it up, and if it's greater than 15, then you can be at risk of some sleep apnea. Some of this stuff, though, I've always taken this myself in practice with a grain of salt, because I don't know, falling asleep watching TV, I don't think is that bad of a thing. But falling asleep while you're stopped at a light in your car is a really bad thing, and there's no stratification for that. But this is one of the tools that your doctor may use when they're looking at any risk of sleep apnea. This is another, this is looking into someone's mouth, and it's called malin potty classification. Don't need to know that. But the important thing to know here is that just different people are born with different areas in the back of their throat. So class 1, if you open up your mouth, you can see way back there, you can see that little uvula thing. and you have a wide patent airway. Class 4, you open up your mouth, you have, you can't even see the back there. Or class 3, you see a little bit of the uvula. So people with a class 3 or a class 4 melon potty or back of their throat are again at a little bit higher risk of sleep apnea. Doesn't mean that they have it, but this is again, as you can see in those pictures, it doesn't take much relaxing to close off that airway at night. So what are some of the symptoms, excuse me, of sleep apnea? And sometimes people don't even perceive some of this, you'll ask you, oh yeah, I sleep okay, but I'm really tired all the time. I wake up unrefreshed. I'm tired after I'm up after a couple hours. Those are some common things we hear. Also loud snoring. Again, daytime sleepiness, restless sleep. You just, moving around. Maybe you also have some restless leg with this. You awake choking or gasping. I've also had people come in and say they dream that they're choking. They dream someone has a pillow over their head or someone is choking them in their dreams. Morning headaches, dry mouth or sore throat because you're constantly opening your mouth and trying to breathe through your mouth to get more air. Waking up frequently to urinate. And many times we just attribute this to, we're getting older and, men attribute it to their prostate problems. But if you're waking up 4 or 5 times or so a night to go to the bathroom, some of that may be sleep apnea, because it's hard to know if you're waking up and then you say you have to go to the bathroom, feel you have to go to the bathroom, or you're waking up because you have to go to the bathroom. And we've had many, especially men in the practice who were up a lot during the night. Not that we cured their prostate issues. They may have been up 5 times a night, and now they're only up 2 times a night when we treat their sleep apnea. So that may be something to think about. Again, we talked about awakening unrefreshed. I've slept for 8 hours. I don't feel any more rested than when I went to bed last night. Also, sometimes memory impairment and difficulty concentrating, like you're sleep deprived. Witnessed apneas or witnessed, stopping breathing. And I would hear that in the days when you still could have your wife or your husband or significant other come into the office with you, would say, oh yeah, I see him stop breathing, all night long. And then irritability, again, because you're sleep deprived and you're tired. So those are some of the symptoms that we see most commonly with people with sleep apnea. So how do we diagnose sleep apnea? Well, the way to diagnose it is with a sleep study. And there's kind of 2 ways to do that. The traditional way is to go to a sleep study lab. And you have like a little hotel room, kind of a cheap hotel room. And they kind of wire you up for sound. You have, and the gentleman in this picture has kind of all the electrodes in that they have on. So they monitor your breathing effort, what your airflow, your brain waves, your oxygen levels, your heart rhythm, and then the duration of your sleep stages and movement. And they have pages and pages and pages of data from all this. So they put all that stuff on you, and then they tell you lights out and go to sleep. So it's a little challenging, and most people that I would have sent to a sleep study have trouble sleeping. But surprisingly, the vast majority of the time, we've gotten good studies, and most people, we need about 4 hours and at least one stage of that, that REM sleep, that deep dream sleep, to diagnose it. And most people are able to do that. And that's kind of the gold standard. We get good numbers, we see what's going on, we watch their oxygens. And if things actually go really smoothly, we can do the second part of the study called the titration study, and talk a little bit more about that when we get to the CPAP. There are also now the insurance companies are approving home sleep studies, which is wonderful. I was very excited when this happened because a lot of people don't want to go to the sleep lab. You don't get as much information. You get the breathing effort, the airflow, the oxygen levels, and the heart rhythms. So there's generally enough to diagnose sleep apnea with that. The problem with home studies are that they're unsupervised, unless somebody wants to stay awake and watch you all night long. So if a monitor lead falls off, the study is void, and you'd have to do it again. So sometimes that's not the best way to go, but it's certainly worth a try if that's what your insurance will cover. But either way, you can diagnose sleep apnea with that. So what they do, sorry, there's a little delay between slides. And this is you don't have to, this is a lot of information, but basically what happens is that the computer counts the amount of times you stop breathing or have apnea, greater than 10 seconds, or you have what they call hypopneas, which is you're still breathing but very shallow. So you have a 50% decrease in the airflow for at least 10 seconds, and your oxygen levels go down. So during the study, those are all counted. And then they divide them by the hours that you sleep to get what's called your apnea hypoxia index. And that's how we diagnose the severity of your sleep apnea. So less than 5 is normal. And you can see from the other things that 5 to 15 is mild, 15 to 30 is moderate, and greater than 30 is severe. So if we talk about severe, we're talking about on average, that person is having 30 or more events an hour while they're sleeping. So of course they're tired in the morning because they're very busy all night. So Medicare guidelines will pay for treatment for sleep apnea for a IHI, which is that apnea hypopnea index, greater than 15. So moderate and above. If they will pay for it, if it's 15 to 14, if you have heart disease, high blood pressure, or really can document a lot of daytime sleepiness. So how do we treat it? The gold standard, the first line of treatment is CPAP. That's continuous positive airway pressure. And that's a picture of a CPAP machine. There's many different kinds, and they look a little different, but they're getting like smaller and smaller, which is nice. So what does this machine do? So if you think back to how we talked about how the airway collapses, a soft palate and the tongue, and it collapses and air doesn't go in. So what you want is to blow air pressure in there to keep that airway open. So it's a mechanical problem, and we're treating it mechanically. So the continuous positive pressure. So it's continuous pressure blowing in, keeping that airway open. Now, it's not one size fits all. Let's go back to the previous one because we switched for some reason. It has to be what they call titrated to your pressure. So that is generally another test in the sleep lab or another home study, depending on the insurance and things. But it will titrate the pressure that you need to keep that airway open and keep that AHI number less than 5. And that's what you will stay at. There's many different masks you can try. Full face, nasal pillows are like a nasal cannula that just goes up into the nose. And we'll talk about when we get, if you need to try different masks, try different masks. A lot of times if they are at a sleep study and they did well with the CPAP, with the mask they used at the study. When they send us the results, they'll tell us that so we can order the same mask. Humidity. So you put some type of distilled water in this machine, so you have humidity to keep the nasal passages and oral passages moist. And that is completely a preference of each person's preference. It doesn't impact the treatment at all. So say like in the summer, maybe less humidity because it's so humid around here. In the winter, you might need more humidity. Desensitize. There's different ways we would talk to people to get used to the CPAP. Everyone, I would say to them, you know, you're not going to go home the first night, turn the lights off, strap this thing on your face, and it's going to be all good to go. Some people it is. Some people, it's like they take like a duck in water. They haven't slept so well in 30 years and they love their CPAP. Most people, it's going to take a little time. And what we would suggest is you work towards getting up to 4 hours. And then work from there to 6 hours, and then work for all out to get to all hours of sleep. And in the meantime, if we need to do mask adjustments or pressure adjustments, we can. The other thing is that works for some people is to put it on in the evening while you're watching television. Get used to it while there isn't that pressure. I have to get to sleep right now, and get used to the mask and while you're up and about. When you start this, you should have at least a 3-month follow-up or sooner. If you're having problems, you know, you need to reach out to the doctor that ordered it, the office that ordered it, or your vendor. You know, it's that first month or so, if you need to change masks or you're having different issues, we want to, you know, get on them so you can get used to that. That said, the vast majority of people using the strategy of working up from 4 hours during the night do very well and get very used to their CPAP. The other thing you may have heard of is a BiPAP. And it looks pretty similar to the CPAP. The difference is that instead of one pressure continuously, you have two pressures. So you have one pressure of air going in when you inhale and one pressure going out. So you have a higher pressure going in, and then when you go to exhale, the pressure goes down so you can breathe out the air easier. That's used for people with really severe sleep apnea that the CPAP doesn't take care of completely. Or they're on really high pressures of CPAP and they can't tolerate them. We can do lower pressures with the two levels. Or someone who's having a lot of trouble with air swallowing. And as I'm saying, if you're having these issues when you start, there's other things we can do. Some people have a lot of trouble with swallowing air. Rarely, I mean, you know, very rarely I've seen that, but sometimes switching over to a BiPAP can help that. So what else can we do besides the CPAP and the BiPAP? For mild, what they call mild positional sleep apnea, like you really only have a lot of apnea if you're laying flat on your back, adjust your sleep position, sleep on your side, put a pillow on behind your back so you don't keep rolling over. Weight loss, and I would tell people it may get the sleep apnea better. I'm not going to promise people if you lose quite a bit of weight, the sleep apnea will go away, because you may still have that been born with a certain opening in your oral pharynx that isn't going to change, but it will certainly help. We'll also I'll talk a little bit about dental devices and some surgical treatments. So dental or oral appliances generally work best for mild sleep apnea or snoring without sleep apnea. We have used them, sent them to these dentists to fit them for these oral appliances, and people who've really tried everything they can, they just cannot get used to sleep apnea. So, we just had a handful of people that happened to. But basically, it's going to go in the mouth. It's going to jut the jaw forward, so the tongue comes forward, so it's not closing up the back of the throat. And it also is going to have an upper part that lifts up that soft palate. So you're opening the soft palate and bringing the tongue forward. So there's a couple dentists in the area that do this. Not every dentist does. It's kind of specialty. They have to fit you for it. And after they fit you for it, they will then repeat a sleep study and see if it is making the sleep apnea better. The downside of these is that you do have, some people do have problems then with their, TMJ, with their joint in here, because it's pushing it forward. Some gagging, things like that. So they have to get a little bit used to this too. But that is an option if you can't tolerate CPAP. Again, CPAP is the superior treatment for especially moderate to severe sleep apnea. The other thing, and you're probably starting to see these commercials on TV for this Inspire device, and it looks really great, they're selling you on a better romance life and what have you with this Inspire device. So what this actually is an upper airway stimulation therapy. So that's a picture I have there of the device. It's about this size. So maybe just a tad bigger than a pacemaker would be. It's implanted under the collarbone like a pacemaker. There's 2 electrical leads. One goes up to the neck to the nerve that stimulates the tongue, and the other goes to the chest wall to track the breathing. And so if your breathing goes down or stops, it will stimulate the nerve that goes to your tongue to flatten the tongue out, get the tongue out of the way. Sorry about sticking my tongue out. So in one of it's relatively new. It's just kind of maybe within, I don't know, last 6 months, 12 months, something like that, got FDA approved. One of the big studies in the New England Journal of Medicine showed that it had a 68% decrease in that IHA number, which is good. It's not as good as CPAP, but it is good. And it had very few adverse effects, only 2%. And most of those had to do with tongue and mouth issues, sore throat, things like that. Not everyone is eligible for this. Let's see if we can get, yeah. And then, so they implant the device, and 1 month after the implant, you can turn the device on. And then they have a period where you kind of, they showed you in the commercial, there's that little outside remote. You can self-titrate it. So you have to be able to figure out what your IHI is and to titrate the pressures. At 2 months, you have a formal sleep study. And again, the biggest complaints were transient tongue weakness and soreness was the most common complaint. So it sounds good, but it's, again, not for everyone. It is approved for people with moderate to severe sleep apnea that cannot tolerate CPAP. And so it's not, yes, I don't like CPAP. It's really, you have to have documentation that you've tried many things, you've tried different pressures, possibly go to a sleep specialist. We do have a couple very good sleep specialists in the area here, through Dent and also Dr. Rifkin's office. Or you're unable to get consistent benefit from CPAP. We tried everything. We still can't get the CPAP to take the apnea away. And your BMI or your weight, that's your basic, your mass index, has to be less than 33. As it goes under the clavicle, you have to be able to use the remote, so you can't be too heavy to have this put in. The only other thing I want to say about the Inspire device, we didn't really have any patients in our practice that had that put in. Again, it's relatively newly approved by the FDA for general use. It has been in studies for a while. My question about it, it does seem relatively safe. We'd have to see what the long-term numbers are, because I wonder if after a couple years of stimulating that nerve, if it would not be as receptive. That's just my own thought. So I would like to see a little bit long-term data. My boss, who's a pulmonologist, always used to say, you don't want to be the first to try something or the last, meaning that you don't, you want to just wait and see how things are going to pan out when you start using it in the more general public. But that is an option. That would be, probably, again, someone who's done a lot of things, is probably going to a sleep specialist, and this would be something they could try. In my experience and in my practice, there were very, very few people who, without working together, we couldn't get them to eventually love their CPAP, which I know is probably hard to believe for some of you who don't love your CPAP right now. And we'd have a few people who had difficult other challenges. Like I know I had one gentleman who was a Vietnam vet and was in helicopters, and he had a lot of PTSD. He just could not put anything on his face, and he was somebody that we did send for a dental appliance. He couldn't get past that, and that's understandable. So when we talk about sleep apnea treatment, what do we talk about with compliance? Because some places, besides which the insurance companies to pay for your machine and your supplies, want to know you're using it and that you're compliant with it. There's also certain occupations, like if you have a DOT license, you drive truck or buses, you also have to prove compliance with your sleep apnea. So compliance is considered that you're using it 5 to 7 nights per week. Now, I want to just say, what we want, though, is you wear it for all hours of sleep is the goal, but this is what they look for compliance. And you're wearing it at least 4 hours a night. And then again, work up to at least 6 to 7. And our goal is for all hours of sleep. Follow-ups are going to be initially 2 to 3 months after you started treatment, and then routinely every 6 to 12 months, depending on how you're doing with your machine and your sleep apnea. Okay, next slide. Again, sorry for the delay. The other things you can do is what we call sleep hygiene things to also help with your sleep and feeling better. First of all, if you can, avoid naps, especially naps later in the afternoon. Establish a bedtime routine. No caffeine after dinner. And I know for some of us, like myself, I can't do caffeine after 3 o'clock in the afternoon. So, and that also includes things like Coca-Cola. So a lot of pops have caffeine in them. Chocolate, hot chocolate. Avoid alcohol and sedative medications, and avoid sleep medications. And let me talk a little bit about that. And we're talking about avoiding these things if you have sleep apnea and you're not treating it with your CPAP. And the reason we want to be very careful with these drugs is that if you remember how sleep apnea works, things close up, you stop breathing or very shallow, oxygen levels go down, message goes to the brain, wake up, take a deep breath, and then you're breathing again. So if you introduce something that interferes with that feedback, like alcohol or sedation or a lot of sleep medication, that could be a real problem because you don't have that, especially the more severe your sleep apnea is. If you don't have that feedback and you've interrupted that, these are the people that get into real trouble, and it could be actually fatal. So be careful with those. If you have sleep, the thing to do is to treat the sleep apnea. And I'm not saying you can't have like a glass of wine or two or something like that, but I'm saying any, heavy drinking or sedative medications, especially the sedative medications that can really interfere with that feedback. We tell people if you're going to have surgery, and most of the time they will ask you this anymore anyway, but if you're going to have surgery or any procedure, like even a colonoscopy where they give you sedation, that's absolutely fine as long as everybody knows you have sleep apnea. If the the anesthesiologist or the GI doctor, they all know you have sleep apnea, then they will be able to adjust things accordingly. And maybe even when you're coming out of the sedation, they'll put a CPAP machine on you. So it's no big deal if everybody knows. It's a little scary if people don't know. So if you're going to have any procedure where you're going to have sedation or anesthesia or a lot of pain medicine, just if you have been diagnosed with sleep apnea, say, I have sleep apnea, I wear CPAP, and they can make allowances for that. So why are we so big on treating your sleep apnea? Well, first of all, we'd like you to sleep better. We'd like you to feel better. We'd like you to get up in the morning and feel relatively refreshed, and not be crabby and tired and having difficulty through the day. There's also some big things that happen, again, when we're talking moderate to severe sleep apnea, within your body. And again, going back to what happens during your sleep, you can see why these these can happen. One of the big things is congestive heart failure. And the heart can't pump as efficiently, fluid backs up, especially downstream in your legs. And again, that's from, if you're holding your breath, those pressure changes within your thorax when you have apnea. Heart irregularities, particularly atrial fibrillation. There is more and more studies out, huge correlation between atrial fibrillation and untreated sleep apnea. It may not be causing the atrial fibrillation, but it's making the atrial fibrillation much more difficult to treat. And a lot of heart doctors now will just, if you come in with new atrial fibrillation and the valves within your heart are all fine, they'll want you to go for a sleep study. Again, difficult to control high blood pressure. Your body is under stress all night long. Your oxygen levels go down. When your oxygen levels go down in your body, your blood vessels tighten up, and then your blood pressure goes up. You have a higher risk of heart attack, of stroke. You also have this problem treating what they call metabolic syndrome. And what the metabolic syndrome is where you have high lipids, so your cholesterols are high, your blood pressure is high, your blood sugars are high, and you're overweight. And again, the sleep apnea may not be causing these things. A lot of these are lifestyle and genetics, but having this untreated sleep apnea makes it very difficult to control these things because again, your body's under stress all night. You have all these circulating what we call catecholamines like epinephrine that keep the body in a stress mode. So your blood sugars are going to be higher, your blood pressure is going to be higher. It's going to be harder to lose weight. And those things all can lead to a higher risk of heart disease. So it all feeds in together. Erectile dysfunction, and then some kidney problems. Again, you're just not getting enough oxygen to the rest of the body. Some other risks are driving risks. 4.7% of adults report falling asleep while driving. And I have to imagine a lot of them don't report it. So that's kind of scary. And drowsy driving accounts for approximately 1,500 fatalities in the US. So that's a big issue too. And it's an issue along a lot of times too with long haul truckers and bus drivers and things, because they have the sleep apnea and then compounded with lack of sleep, and their whole bio rhythms are off. So just some other studies. This one, the first one from the American Sleep Association in 2016, said that untreated severe sleep apnea was a significant risk for heart problems and death from heart disease. So cardiovascular morbidity and cardiovascular mortality. So having heart disease and dying from heart disease, and 30% higher risk of heart attack or premature death in untreated severe sleep apnea. Again, we talked about a strong association between sleep apnea and atrial fibrillation. And a study way back in 2006 showed an increase in all-cause mortality, so all-cause deaths, with untreated moderate to severe sleep apnea. So what that's saying is people with moderate to severe sleep apnea and it's untreated have a shorter lifespan than someone who doesn't have sleep apnea. The other thing, more and more studies are coming out about cognitive impairment with sleep apnea, which makes sense on two levels. First of all, if you have moderate and particularly severe sleep apnea, you're chronically sleep deprived. So you have all those symptoms of being chronically sleep deprived, what we call executive functions, your ability to pay attention, and your memory and calculate things. And then also, the brain needs a lot of oxygen. So it's also suffering from a chronic problems with oxygen during the night. So they estimate 1 in 4 people, again, this is untreated sleep apnea, with some cognitive impairment, fine motor coordination impaired, memory issues, and again, those vigilance and attention. So those executive functions are impaired. There's also been a few studies out within the last 2-3 years seeming to say there's an increased risk of dementia, Alzheimer's, and untreated sleep apnea. So I know there was a couple questions coming up. So let's. So Kitty, if I do the chat, or you're gonna, how are we gonna do the questions?
I'll scroll back and read the questions, and then I'll open up the mics if people want to speak their questions.
Okay.
So one of the first questions was, what follow-up should be done following the diagnosis and beginning treatment with CPAP?
Okay. So once you start the treatment with the CPAP, again, if you're having trouble or different masks, you can follow with the vendor, but you need to follow up within 3 months with who's managing your sleep apnea. Sooner if you're having problems.
And so,
Sometimes we could help out with things just with a phone call. Try this, try that, you know.
good advice. Should a repeat sleep study be done every few years?
Not necessarily. If things are going well, and especially now with the new machines that are hooked up, that have Wi-Fi, you can get an app that will tell you every night, if you want, what your IHA is, what your number is. And so if things are going well and you're not having any, you know, you were sleeping fine and now you're not, and if that number stays pretty consistently below 5, you don't need to keep going for sleep studies. Now, where you will, if you stop using your CPAP, you know, and then you want to start using it again, many times you'll have to go for at least the titration part of the study, depending again on, you know, your insurance may say you need a whole study again. But if things are going well, again, with the new machines, we can download reports that tell us exactly what's happening at night.
Okay, and that might play into the next question is, how do I know my machine is working correctly?
Well, again, most of the newer machines have on the panel, you should be able to get to something that says like options and then what your numbers are. There's also an app you can put on your phone or your iPad that will give you your numbers every night. You know, well, you know, they'll give you in the morning what your numbers were that night, and also a report. If you don't have that, or you don't haven't been able to figure out the app, call your vendor, whoever you got the machine from. They can test it for you. Generally, through the Wi-Fi, they don't even need to, you know, bring the machine in, but and they can walk you through it. But they can test your machine.
Oh, wow. And then there was a question for me. Yes, we will have this posted to our website at erie.gov/University Express. And it's under the classes tab at the top of the page. So you can go there and review this or send it to someone you think may be interested in the topic. Now,
Kitty, I just see from Christine, my original
yes.
vendor is out of business.
Oh, okay, yes.
Yeah.
And an old
So
machine.
here's another idea. I don't know if you're getting your CPAP supplies locally. So if you're getting them from a different vendor, they can help you. Um, since, you know, they've taken over your case or whatever. I don't know what the right word is for that, but if you are getting your supplies from a vendor, they should be able to help you with the machine.
Okay.
Okay. I know there's been a
Yeah.
lot of a lot of places going out of business, and a lot of the different vendors getting the, you know, preferred contracts. So it's a little bit difficult that way, but I would consider whoever you're getting your supplies from, your vendor, and see if they'll help you out. But if you can figure out on the panel or getting the app onto your phone. Now, the other thing I'm just thinking of, if your machine is so old that it doesn't have this Wi-Fi feature, it's probably you're eligible for a new one. I think Medicare, you can get a new one every 5 years or so. And you just, you know, so you may, if it's that old that you can't do a Wi-Fi on it, you may want to think about getting a new machine. You'd be eligible, I believe.
Great advice. Now I'll open it up. I want to try it this way. So if anyone has a question that they would like to speak, instead of using our chat area, if you see the raise your hand icon at the bottom of the page, you can click on that, or you can do Control Shift R, and then I'll see you and I'll unmute you. So that raise your hand icon at the bottom of the page, or Control Shift the letter R. I'll just give everyone a few seconds to see if we have questions. Okay, and I have a question. Let's say, so people that I talk to who have potentially have sleep apnea, they really don't want to go to that sleep clinic because they say they won't sleep. And you had mentioned it earlier. So really, as long as you can get into REM or like an hour of sleep, is that all they would need?
They generally need 4 hours of sleep to diagnose sleep
Okay.
apnea. And if they can get a couple or, 1 or 2 periods of time that they're in REM, that would be good. And again, surprisingly, most people do sleep. I can only remember a handful of times where we just couldn't, someone just couldn't sleep. They all say they can't. I didn't sleep a wink, but they did sleep some. So you don't, if we could get a few hours, like usually 4 hours is what they say.
Okay.
Sometimes too, with the more severe sleep apnea, it doesn't take long. It takes like the first hour. You're in they're in bad shape. So I would encourage them to do that, to go. And I'm actually, walking the walk, and then I've been there. I have sleep apnea, and I think it was about 2 years of my doctor telling me I should go have a sleep study before I went and had one, because I just wasn't going to do it. And then I thought to myself, well, I can't be telling all my patients to go, and I don't do it. So, you know,
Interesting, right,
it
right.
isn't that bad, and if uh, you do sleep a bit, and I do, and people don't believe it, but I do encourage people that once you make friends with the machine, the vast majority of the people don't want to sleep without it because their sleep is so much better. But you got to give it a couple months to make friends with it.
Okay, wonderful. So doesn't look like we have any more questions, but everyone seems to have enjoyed the presentation.
Thank you all. I enjoyed doing it.
And don't forget that this will be available for you to share with your friends or family members who may be suffering with sleep apnea. So thank you, Sue, for coming on, and we look forward to talking with you again in the fall.
Okay, thank you very much.
Have a great day, everyone.
Bye-bye.